here we are, and I don't think I need to convince you that in this day and age, you cannot afford to not be what we call research literate. I mean, it is really important. Any one of your patients can instantly tap into medical research, into acupuncture research, and you need to know how to respond. You need to know how to read the article that they bring in that says acupuncture is going to cure my hiccups, and you have to know if this research was done well enough to believe the outcome. You have to be able to talk to your patients, and you have to know about this. And you need to be able to talk to people in the biomedical community about acupuncture research. And when they say, oh, we know all this stuff, it only works a tiny bit better at best than sham acupuncture. You need to know what sham acupuncture is, and you need to know how to talk back to them and say, no, that's just the wrong conclusion. We were talking this morning when I gave the CEU, and one of the things that came up is if a drug study comes out and it says that this drug doesn't work, nobody would conclude from that that pharmacology doesn't work. So when you read an acupuncture study and it's negative, it doesn't mean that acupuncture doesn't work. That's what people say. Oh, acupuncture, I saw this study, acupuncture doesn't work. It means that particular point protocol wasn't effective when given that many times per week for that many sessions to this particular patient population. That's what it means. And if a drug study doesn't work, quote, doesn't work, they try a different dose, or they try a different drug of the same class of drugs. Or they'll try a different class of drugs. We know for blood pressure there's at least four different, totally different kinds of drugs that are used. So you want to either switch the drug or switch the combination of drugs. So don't let people tell you that acupuncture doesn't work because they read that acupuncture doesn't work. It's that particular problem. When you see a patient and you're treating them in a certain way and they're not getting better, you change the point protocol. So that's what research is all about. It's testing. And let's go to a few slides, because what I want to leave you with is research is one way to get information on which to base your clinical decision. But there are other ways that are equally as valid, not instead of research, but together with research. And it's not, so I don't like this term evidence-based medicine at all, because you can't do anything, you can't, use a Kim wipe, you can't use a tissue if it's not evidence-based. We call it evidence-informed practice. So evidence or research is one of the things that helps you inform your practice, your clinical decision, but it's not the thing. And so evidence-based medicine is being used too much as a kind of cudgel, especially by people who like to call themselves skeptics. And it's these people who call themselves skeptics that give the term skeptic a bad name. Because we all should be skeptical. As practitioners, as researchers, you're supposed to be skeptical. But the kinds of people who call themselves skeptics don't want to know about the data, don't want to know about the evidence. They've already made up their mind that acupuncture doesn't work. At best, at worst, that acupuncture is all placebo. So it's a real problem sometimes it's not worth, as I've seen, it's not worth debating with these skeptics, because it's not a rational-based debate. They just want to let people think this is all, I don't even want to figure out which pejorative word to use. But so research is a way of knowing, and that's an important concept in itself, and we'll talk what that means. And one of probably the first article that talked about so-called evidence-based medicine was subtitled "What It Is and What It Isn't." And it's important even now, though it's it's a fairly old article now, it's really important to go back to that to be able to know what that article originally said about evidence-based medicine, especially what it isn't. So that will lead us to what kinds of acupuncture research are being done, and why there's a trend now away from this so-called sham acupuncture research. These controlled trials where you randomize patients and some get the real acupuncture and some get fake acupuncture. And why that kind of research hasn't gotten us anywhere, really. And instead of that, what we want to do is research that compares acupuncture to other kinds of interventions. When you have a patient, I think I used the example this morning, is what I thought of tennis elbow, and you have one study that says acupuncture is better than sham acupuncture for treating tennis elbow, and then another study says acupuncture is as good as steroid injection for tennis elbow, but guess what? Acupuncture has many fewer side effects than steroid injection. Acupuncture is as cost effective as steroid injection. Acupuncture kicks in sooner than steroid injection, and it lasts longer. Okay, so you're getting all this other kinds of information that you can't get from a placebo or sham controlled trial when you do this new kind of research, which is called comparative effectiveness research. And that, I'm happy to say, is the trend in research now. We're saying, we're comparing acupuncture to a beta blocker for migraine. We're not comparing acupuncture to sham acupuncture for migraine. So this real-world research is called comparative effectiveness research, and it also includes a kind of research which is whole systems research, which is very exciting, which is research that's just beginning, which says that what we want to know is when patients come to you, they're not just being treated with acupuncture. They're also getting herbs, they're getting tuina, they're getting maybe gua sha, they're getting lifestyle counseling, they're getting other kinds of treatments. So why are we only doing research on acupuncture? So a few of us are trying to push this idea that we need a research design that compares TCM to biomedicine. Okay, so we're not, so that's another part of comparative effectiveness, comparing whole systems of care. So one of the most important things about this afternoon that I want to leave you with is when you do, and a patient does bring in an article, or when you're curious, if you start to specialize and you want to keep up with the acupuncture research in a particular area, how do you know if a particular article is reported well enough so that you can believe the results, was designed well enough to answer the questions they asked? So I've developed over the course of years, which I started way back in Yosan, and I've refined and refined and refined, and I've got it down to like 10, and I call it the CLEAR, which stands for Criteria for Learning to Evaluate Acupuncture Research. That's what the CLEAR will be. So we're going to come up with a couple of articles and going to have you apply these criteria to the articles and get a sense so that before you get disappointed that a particular study was negative or get excited about a particular study that was positive, you really need to see, was it designed and reported well enough so you can believe the results? That's really important. So that's what we'll go over. And finally, I want to hope to instill a kind of curiosity enough in you so that some of you will be interested in doing various kinds of research. What kinds of research can you get into? How do you do it? And how do you keep current with the kind of acupuncture research that's being done? So that's the chunk that I hope we'll have time to cover this afternoon. So This, I have to tell you, was that's the best I could do with animation. Except this outside, the way I originally designed it, moves this way. So it's really outside the box. But I think with acupuncture research, we can't simply say we want to test acupuncture as if it was a drug. It doesn't work. Shouldn't be done. Shouldn't ever have gotten into that line of thinking. Acupuncture research should never have been allowed to start using the drug model to do research in placebo. Not the least of which is, a drug model says we're going to give everybody the same drug, the same dose of the drug for the same number of times. I mean, that couldn't be, what's the point of testing acupuncture and asking, is acupuncture an effective biomedical treatment? That's not what we're about. Okay? So we have to be able to say, yes, the research has to be rigorous enough to satisfy their community, but the research has to reflect the values and the explanatory model of TCA. So, people often say this to me, okay, acupuncture has been around, practiced successfully several thousand years, so why do we need research? Okay. So the easy answer, the most direct answer is that research is a resource to improve your clinical decisions. Okay. So why else is acupuncture research valuable? Why else should we bother to take the time, put the money, hopefully, in doing research in acupuncture?
Educate the public.
Educate the public. Educate the public. And that there's a way in which acupuncture has to meet the criteria of any kind of intervention, and that is not to label it, I think I have a quote coming up here. Yeah, not to label it as something that's mainstream or alternative, conventional or complementary. So this is Dr. Berman, who directs the Center for Integrative Medicine at the University of Maryland. He says any decision concerning which therapy is a viable healthcare option should be guided by the question, does it work? Not putting a label on it first. Okay. So the question really is, what does that mean? Does it work? Do they work? Because I think that question is very different depending on who's asking the question. So a patient wants to know, obviously, can you help me get rid of my migraines? Okay, will acupuncture work for me, for my condition, yesterday? Right, that's what the patient wants to know, or at least in a week. So in LAC, when they say, does it work? They want to know, is it not going to work just for this patient? Is it going to work for all the kinds of patients that I see? Is it going to work more often than not? Is it, am I learning something here that's going to give me a good living? Because I can treat 80% of the patients that come in my door. Okay. What does it work mean to a hospital administrator? Okay. Often that can mean if I introduce acupuncture into my pain clinic, am I going to get better outcomes? In what conditions should I or might I consider adding acupuncture to particular wings of my hospital? Is acupuncture viable in childbirth? How can I make my hospital run more efficiently? How can I shorten the length of time? So does it work mean something different to a hospital administrator? To a health policy wonk, we call them, a health policy wonk. So what could that mean? It could mean, is there enough data to suggest that acupuncture should be part of a national health insurance plan? Should we recommend reimbursement for acupuncture? So does it work well enough so that a large number of people can be covered for a large number of conditions, or a smaller number of conditions, but that's how they think. To a physiologist, does it work really means, how does it work? Does it work? And most of them want to know, how does it work in our language? I mean, you probably have the experience that when you talk to people in the biomedical community, it seems to me they often want to know if you can speak their language before they'll listen to you, talking about acupuncture or Chinese medicine. They want to make sure that you can talk to them. So when they say, does it work, they want to know in their language, does it work? They're not interested so much in the TCM explanatory model. They want to know, how does it work? They want to know what's an acupuncture point. They want to know what's a meridian, right? They want to know, what does the needle stimulate? Is there an acupuncture? They're thinking nerves, so they say, is there a signal from acupuncture? They think nerves, so is there a receptor? What is the signal going to? So they want to know all these questions. We're not there yet. We just don't have these kind of answers. But it helps us frame to really understand that kind of thinking of where certain kinds of research should be going. So what I'm getting at is research occurs within a way of thinking, within a kind of context. So you can do research within a TCM framework, and that's really important. Japanese needling is very superficial. Chinese needling is deeper. What's going on? Why are they different? Do you really need to elicit Tai Chi to get positive outcomes? So there are lots of good questions to be asked that haven't been answered within the TCM framework. How do you know how long to retain the needles? How do you make that decision? Seat of the pants, do you always just do it 20 minutes for it's convenient, 30 minutes because it's convenient? How do you know? So there's lots of those questions within the TCM explanatory model. Within other models of acupuncture, I mean, surely there needs to be research on Toyohari-style Japanese acupuncture. How can you possibly get healing without penetrating? It's called acupuncture after all. And here's this whole branch of needling, Toyohari, which says you don't have to you can just hold the needle over the point and maybe focus your your intention. And by the way, what is that about? How do we do research that shows that acupuncture is more than just the physical manipulation of the needle, that I mean, so much of, when I read so much acupuncture research, what I realize is they're asking a much too limited question. They're asking, does the needle work? They're not asking, does acupuncture work? So I would love to somehow get in touch with a sum of money and put up a prize for the person who can do the definitive research study that shows that or intention, is a critical component of healing in addition to the needle.
It's like a scalpel, does a scalpel work? No one asks that question.
Does it work? Scalpel, well, we know it cuts through the skin. We know.
And isn't work in
peels
physics
back the
defined
layers.
as some kind of activity that expends energy?
Does which?
Work in physics, it's an activity that expends energy.
Oh, okay.
There's an entropy.
Yeah.
So the scalpel is inert. It's just hanging out.
But it's doing work. I mean, it's you're releasing energy when you're cutting open tissue, when you're cutting through those layers. So, yeah, I don't think you could make the case that there's a serious component of intention when you're working with a scalpel in the way that there is potentially that other component when you're doing the needling. So that's something to think about.
Well, I mean, there's different techniques to cut, right?
Yes.
So
And there's different techniques just to needle, to manipulate, or the angle, or the depth, or all of those that have nothing to do with intention. So
Okay.
I mean, I'm not saying that there is that other component of it, but a lot of the textbooks say, and you certainly read a lot about it in the martial arts literature, about about intention. Not so much, people tell me, translated in English in acupuncture, but most of the classical textbooks talk about the component of intention and needling. So, anyway, research occurs within the conventional biomedical model. They want to know how a hormone is active, or what genes are upregulated when you sneeze. So they've got all these techniques now to tell whatever you do to look at the pattern of up and down regulation of genes. Emerging biomedical models rather than conventional models, what we're learning about the connective tissue is it can be a whole new way of looking at the body. The whole concept of when you have a painful, stiff shoulder, well, guess what? It's not just this area that changes. The whole body changes to compensate for that stiff shoulder. So we're learning much more about the fascia and the superficial connective tissue as a whole body network. Okay. Emerging energetic models. Like I said, we still don't, what I'm interested in now, we have some ideas of how to explain the benefits of massage, or even of just light touch, of health benefits. We don't have a clue of how to explain external qigong that doesn't involve physical touch, or Reiki, or therapeutic touch, or Jo-Rei, all of these sort of cousins, this whole family that in many ways derive from laying on of hands, except this is just passing the hands over the body. We don't understand that at all. So, once we get to the emerging energy models, this can lead us back to really important information about understanding East Asian-based models of health. So research also occurs within a model of reality. So this is a very famous painting by a Belgian painter named René Magritte, and it's famously, he wrote that on the bottom of the painting, which translate roughly as, "This is not a pipe." So what does he mean? This is a painting of a pipe. And in this case, it's probably, a scan of an electronic version of the painting of the pipe, so more and more. So in the same way, I would love to have somebody do a nice rendering of a molecule, say caffeine or chlorophyll or whatever thing, and write in French under it, "This is not a molecule." Because a molecule it's not like, it's taking a beautiful butterfly and smashing it and putting it under glass and saying this is a butterfly. A molecule is a three-dimensional structure that's constantly vibrating and constantly moving, and the way we put it in any textbook with sticks and balls is just totally wrong. Totally wrong. So this is not a pipe. So reality. So a lot of Eastern ways of thinking tell us that reality is an illusion. There's a kind of curtain between us and reality, and we have to strip away the curtain, but reality is an illusion. A very pragmatic way of talking about reality is just an accumulation of experience. Then we get to the scientific approach, that the universe is made up of a set of verifiable laws, and we have to just understand what they all are. And really, reality is somewhere in this whole spectrum of concepts. And the quote I like best, some of you may know that great late 20th and 21st century philosopher Lily Tomlin, who famously said that reality is nothing but a collective hunch. So that's another way. What is reality? But so how do you try to see what's there in research without saying what's the perspective we're looking at it from? So this is an important thing. This is something that we would all have more fun discussing at about 9:30 in a pub rather than at just right after lunch. But here we are. So I have to go one step further and ask, okay, we're getting to evidence from a way of looking at things in a reality. What do I mean when I say I know something? What do you mean when you say you know something? Okay, so usually what people tell us is, well, knowing is a combination of what's called empiricism and rationalism. So empiricism is observation. I know something because every time I look at it, it always seems to appear the same way. So that's one way of knowing, observing. The other way is using logic. There seems to be a connection between these two things. So, when I get bored, I yawn. So I know that I'm getting bored because I'm yawning, so I'm making this logical connection. So clearly, I think we can think of how these two ideas work together in the development of Chinese medicine, because whereas I think you could call Chinese medicine, or certainly the development of it, experience-based medicine instead of evidence-based medicine, because you're looking at, you're watching an animal, and the animal got injured, and you see the animal's bleeding, and then you see the animal go over to a particular patch of green and start rolling in that patch of green, and guess what? The bleeding seems to stop. So you make, you observe, and you observe another animal, you see the same thing, and so then you make the logical jump that maybe there's something in that plant, in that herb, that causes the bleeding to stop. Okay. So you can then test that on a patient, and if it works, you keep that herb, and then you find that another animal uses a different herb, and you put those two together, and it works even better than the first one, or it works better than the first for stopping the bleeding, but then it causes headaches in the patient, so you don't want to use that together. So this is what experience-based medicine is. We derogatorily call it trial and error, but a positive way of saying it is experience-based medicine. You keep what works and you discard what doesn't work. You constantly modify, and when you have a couple of thousand years to try this out, you come up with a pretty amazing list of herbs and combinations of herbs. Okay, so we've got the empirical, the observation, and the rational, the logic, but I would say that there's an important way of knowing that's missing here. Who's got an idea of what that could be? And I bet that most of you use this other way in your practice, in one way or another.
Do you mean instinct?
What?
Do you mean instinct?
Instinct, yeah. Another way of saying instinct would be intuition. And I'm on the side, intuition is one of the things that fascinates me, because I think what separates a good practitioner from a great practitioner is intention and intuition. And I think if I could do a research study and I could get 20 students, 20 acupuncture students, and 10 of them had a long practice of Qigong, and the other 10 didn't, but both had the same amount of training and experience, and I could take, well, the problem is you can't get 20 exact patients. If I could take a patient and clone them, so all these 20 different practitioners could work on the same patient, then I think fairly certainly that those who had the Qigong training would have better outcomes than the ones that didn't. Because that Qigong helps you focus your intention for whatever that is, and I think that that would make for a better outcome. The other thing is this intuition. I believe there are ways to develop intuition. I think there are people who have studied what intuition is and could come in here to Yosan and teach a seminar. Not a whole semester course, but give a seminar or give up, you know, a series of courses and help you develop your intuition. So what do we mean by intuition? I think people talk about two different things. You know, someone like Mao and Dao, who've seen now thousands and thousands of patients, a new patient walks in the office, walks into their clinic, and they immediately have, what, 50, 60, 80% of the diagnosis, because that patient is bits and pieces of so many other patients they've seen, and without thinking about it, they're looking, they see facial diagnosis, they smell, they see how the person walks, they look at the color of their skin. There are all these things instantly without having to go through a checklist. It happens. So it's information available through the normal senses, but it happens extremely quickly, and we call that one kind of intuition. The other kind of intuition is some kind of direct, is what I said, immediate access to knowledge that we don't know how we got it. And we haven't seen the patient before. It's not because the patient reminds us of anywhere. We just know that something we know, or you know, you don't even know who the patient is. You get a sense that you're going to be seeing a patient with a particular condition the next day. You just get this knowledge. So I once went to a really interesting conference at the University of Minnesota called Ways of Knowing, and one of the things they focused on was intuition. So I collected just a few quotes that I'd like to share about intuition. So Willis Harman, who's no longer with us, was the president of a place called the Institute of Noetic Sciences. Do you know about this? It's up in Petaluma, Northern California. So the place, Institute of Noetic is a wonderful word which in itself means other ways of knowing. And it was started by the astronaut Edgar Mitchell because he had this amazing epiphany from outer space, seeing this little fragile ball that was our Earth, that he just wanted to really focus on broadening people's understanding of the fragility of life and Earth and everything. And he started this place called the Institute of Noetic Sciences, and they do just, you know, in your copious spare time, you know, I have to share an acronym with you. I love to make up acronyms, so like I made up the CLEAR. So one of my favorite acronyms is NEST. When people say, oh, and I say, that sounds interesting, I'll put it in my nest. And I'll get to it in my nest. And NEST is my acronym for non-existent spare time. So in all of your non-existent spare time, sometime Google Institute of Noetic Sciences and just see what they're up to. Anyway, so Willis Harman said, most of us live at the periphery of our consciousness. Intuition invites us to the core, to the center. It's a lovely thing to think about. This is a quote by a patent office clerk in Switzerland or Austria, I can't remember where, maybe Germany. But so he said, the intuitive mind is a sacred gift, and the rational mind is a faithful servant. We have created a society that honors the servant and has forgotten the gift. So lovely, lovely quote by a man who did a lot to change the way we think about the world we live in. And finally, at this conference was a man named Dane Silva, who was a native Hawaiian healer. And he said simply, intuition is to the healer as space and time are to the physicist. So you live in a different way, in a different relationship to knowledge, to the world, when you are a healer. So, keeping a little bit on the same line with this sort of philosophical understanding of what research is, so we always say seeing is believing. You know, that's a common phrase we use, and you would really have to do some serious seeing is believing to believe if somebody just told you about this weird creature with these humps and what they look like, and knobs at their knees and knobs at their ankles, and in fact, so somebody said, well, somebody showed me this old veterinary textbook, acupuncture veterinary textbook, and it turns out that camels in the what would it be, the northwest, the desert regions of China were used. And so along with horses and other work animals, camels were used, and so there's a whole system of acupuncture points in the camels. So it's part of our seeing is believing. So the HN is the head and nose area, the FL is the flank, the T is the trunk, and the HL is the hind limb. So those are the 4 regions in case any of you have to suddenly be called to treat a camel. You at least know that much. So we say seeing is believing, but we have to always remember that we don't always, that what we see is based in our belief system. So it may also be that believing is seeing. So we ask, how do our beliefs influence what we see? This is really important when you see a patient. You want to keep open, an open mind, that Zen mind, that child mind, and not simply say, oh, I already know what the problem is, because it may not be, you may not be seeing clearly. So here's a picture of a desert sunset. And why am I showing this? Because guess what, guys? The sun doesn't set. We still use this phrase, even though we know it's wrong, right? Sunset should be called earthrise. Right? The next time you're in the desert, or the next time at the beach, when the sun is setting, the earth is rising. I mean, just visualize that earth rising. It's wonderful to have that other perspective. Just like sunrise is earth set, so you don't see the sun anymore. Here's one of the earliest studies of acupuncture, earliest published studies. And what they did briefly was they used medical students in the time-honored tradition of using medical students for research. And what they were looking at was simply acupuncture analgesia. So this is very early days, 1973 was this study. And just for historical purposes, we should remember that 1973 was the height of the Cultural Revolution in China still. And in those days, if you did a research study and published it, you weren't allowed to put your name on it. You published it in the journal, that name of the editor wasn't allowed to be put on the journal. There was no cult of personality allowed in those days. So this study was, in 1973, was published by the first laboratory for study of acupuncture analgesia from the Second Friendship Hospital in Beijing. And people sort of knew somehow who that was, who did the study. But in any case, and it was, 1973 of course was pre-Pinyin, so this was indicated as acupuncture at, what did they used to say for Hegu? Hoku, yeah, Hoku is what it was called in the pre-Pinyin days. So what they're doing is they're starting acupuncture, and they're doing acupuncture out to about 80 minutes, and they're finding that as you continue the acupuncture, the pain threshold increases. Okay, don't need to go into the details of how they show that, but it's a very gradual increase so that you get maximum analgesia after like 30 to 40 minutes. And what that means is something is gradually building up in the bloodstream over that time to increase the analgesia. As opposed to, if it was the nervous system, you would expect a very rapid onset. And the same thing is when you stop the acupuncture, you get a relatively slow decrease of the pain threshold back to baseline. Again, if it was strictly the nervous system all the way through, as soon as you stop the acupuncture, you stop stimulating the nerve and the response would drop right off quickly. So that's background to the second part of the study, because what they thought of to do to really nail the fact that the nervous system couldn't be involved at all, they decided to inject procaine, local anesthetic, into the acupuncture point first and see what would happen. And what happened was it completely blocked the response. So they decided that the initial phase of acupuncture, the initial response to the needle, was through activating the sensory nerves because procaine blocked it, okay? And the problem is, the belief system was that we know that a local anesthetic blocks nerve conduction, and therefore we conclude, or they concluded, that the needling effect is mediated initially through nerves, okay? But their belief system got in the way of the real interpretation, because now, with increasing evidence to suggest that it may be the connective tissue that acupuncture is stimulating, their data is correct that procaine blocks the effect, but now we need to study the effect of procaine on collagen fibers. We don't know what that can do. So maybe this is not, the interpretation is wrong, but your belief system can get in the way of the interpretation. That's what I'm trying to say. Okay, evidence. As I said before, evidence is what you consider when making a clinical decision, but what you read in your textbooks, in the classical textbooks, in the modern textbooks, that's also evidence. That's suggesting what people have found works. And it's worked enough times that they put it into their, codified it in the textbooks. That's the kind of evidence. Your clinical experience, for God's sake, that's evidence. You've had other patients in the same condition. That's going to help you in your clinical decision what you're going to do. If you're really stuck, you call up some of your colleagues and say, I've got this really tricky patient. Have you had anything like it? What should I be doing? That's also evidence. What you read in the scientific journal articles from what people have formally done in research, and we know from what I've been saying, and probably from what your sense is, research is often done in very carefully controlled conditions that don't really reflect the extent that they should of what's happening in the real world. But nevertheless, that's one kind of evidence, and I would make the case that your intuition should be listened to, so you know when you can really trust your intuition and when maybe not. But that's another kind of evidence. You then put all of these together and make your clinical decision. So I don't like to hear that any kind of intervention has to be evidence-based, because too often they think evidence-based means only scientific research. Okay? So in this context, evidence is one way of knowing. It's a pretty good way of knowing. I mean, that scientific research is one way of knowing, but it's only one way. Okay? So now we've got the problem of facing what then is evidence-based medicine. So the original article was by David Sackett, who is an epidemiologist, and he was writing this article in the Biomedical Journal. And you know, I have to say that this is one of the most beautifully written. It's only about 2 pages, and if you ever want to, you know, in your nest, in your copious spare time, it's such a beautifully written article that it really bothers me how people have just run with it and misinterpreted it. But here's a wonderful phrase that he defines. Evidence-based medicine is the conscientious, explicit, and judicious use of current-based evidence in making decisions about the care of individual patients. So when do you ever see the word judicious in a scientific article? It's delicious, judicious, it's great. So this is the most often quoted sentence from the article. But people forget about the very next sentence after that is, the practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. So right away, he is saying, he's almost anticipating the flack he's going to get, and said, no, let's be clear right from the start, by evidence-based medicine, I don't mean just scientific research. Okay? And the subtitle of this article, which was written as an editorial, is not only evidence-based medicine, what it is and what it isn't, but right at the top of the page it says, it's about integrating individual clinical expertise and the best external evidence. So when people tell you acupuncture isn't evidence-based, first of all, they need to be educated about what the real definition of evidence-based medicine is. So what happened was, this very, how shall I describe it? An article that raised a lot of hackles came out in 2006. And what their claim was, their central claim was that the evidence-based movement in the health sciences is outrageously exclusionary and dangerously normative with regards to scientific knowledge. So they said, as such, evidence-based medicine constitutes a good example of microfascism at play in the contemporary scientific arena. So they had a good point, they just went way overboard in making their case. And I mean, using the word fascism in any way, shape, or form these days is just a no-no. And I think there was something going on about David Sackett was in one hospital in Canada, and these guys were at a different hospital, and there may have been some kind of competition or something else was going on. But using this term microfascism. But then when I went back to David Sackett's article, he had sort of anticipated this level of critique. And he said, without clinical expertise, practice risks becoming tyrannized, that's the Canadian spelling of, with an S, tyrannized. Practice risks becoming tyrannized by evidence, for even excellent external evidence may be inapplicable to or inappropriate for an individual patient. So he's laying it out really clear that he doesn't want evidence-based medicine to be narrowly defined. So AOM, part of which TCM is a part, I've said sort of the same thing in three different ways, these first three items. We need to build our evidence base in according with our own ways of knowing. We need to design and perform research with rigor and respect. As I said before, rigor with the science, so that it'll be scientifically acceptable, but with respect for our own explanatory model. And a friend of mine says the same thing in a different way. He says, beware of the paradox of measuring Chinese distance with a Western ruler. So don't simply think that using very rigorous Western outcomes is going to give you the fullness that you need to understand the outcome of Chinese medicine treatment. I mean, so often you find that the patient comes back and starts telling you things that you really didn't, you weren't aware of, or you didn't consciously set out to try to treat, and yet your treatment was helpful in a much larger context. So, as I said before, we need to stop, I think, using the term evidence-based medicine, and more people, this is not unique to me, this idea, but it's sort of spreading, so that what we're using the phrase now is evidence-informed practice. So evidence is one thing that informs your decision, but it's not to say that you can't make a move without showing what the published research is. So the published research helps you to make the decision. Okay, so do we want to take a couple of minutes break now and come back and start this? Why do we do this and start this second session about how to look at the quality of research and research? I decided this is the first ever recorded RCT, randomized controlled trial of Chinese medicine. So this dates back to the Song Dynasty, 1061. It was said that in order to evaluate the effect of genuine Shandong ginseng, 2 persons were asked to run together. 2 persons. One was given the ginseng, while the other ran without it. Okay? After running for approximately 3 to 5 li, which I come up to find is roughly in the range of a mile, 1,500 to 2,500 meters, the one without the ginseng developed severe shortness of breath, while the one who took the ginseng breathed evenly and smoothly. So what's the shortcomings of this randomized control? Who wants to start?
Very small sample.
Very small.
Yes.
Therein lies the road, yes.
How much
So-
ginseng did they take?
Oh, and how did they pick these 2 runners? So,
Did they sign consents?
did they what?
sign consents?
Consent, right.
Was the IRB approved?
So,
They changed the criteria right before the run.
so let's say we're not even doing 2 runners. Let's just say we're going to do 1 runner, and we give them ginseng, and we test them before we give them the ginseng, and then after the ginseng. And even though they're tired, we wait enough time before we do the repeat with the ginseng, and we get a positive result, they did better after the ginseng. How could we explain this positive result as not being due to the ginseng? What other,
Could be placebo, could be evaluated.
yeah? So what does that mean, could be placebo? What,
They just did better because they knew they were being watched.
good?
Because they've done it before.
Because,
They've done it before.
yeah? But
Yeah,
let's
some-
say they haven't done it, let's say
One of them
let's say they're Chinese runners and they've never had ginseng before.
One of them has asthma.
Oh, okay. Yeah, so this is one of the original performing enhancing drugs back in the Song Dynasty. So, right, talked about the placebo effect. So, the runner expected to do well, and might have done well if they'd been given placebo ginseng, he might have done, or she might have done well just because they knew they were being given something supposedly to help them. So the coach's expectation of giving them ginseng could have rubbed off on the runner. The runner wanted to please the coach. The runner wanted to please the researcher. So all of these are kinds of possibilities of what's now, instead of becoming called the placebo effect is a kind of dumping ground term. So we're starting to call it the meaning effect, because there are parts of the placebo effect, for example, what would be a part? So there's something called regression to the mean, which sounds like a statistical concept but really isn't. And that means your patient comes to see you at a time when their pain is worse. So it wasn't, it wasn't what you gave them or what you did, it was because the pain naturally got better. It just waxed and waned. So that's not part of what we're now calling placebo. That had nothing to do with the expectations or the meaning of being in a research study. So this is what we've been talking about, of how all the ways a positive outcome could be explained as other than the ginseng, or in a particular single patient case study, how can you explain the outcomes as not being due to acupuncture if you're treating with acupuncture. So we've got all these placebo effects. We talked about regression to the mean. The natural history of the disease is many diseases just wax and wane by themselves. You treated them at a time when the disease was just ready to wane of itself in terms of its natural history. You know, we said this before, the positive life event of the patient. So right before you treated the patient fell in love. Not with you. So the patient fell in love, changed their whole hormonal balance, and that led to, that was a major part of the cure, right? Nothing you did. Okay. And then there's this thing which, for lack of a better term, is called spontaneous healing. In the old days, it used to be called miracles. Now we call it spontaneous healing. See, if you want to do research, you can't call it a miracle. You can't say I'm studying miracles if you want to get funded. But if you call it spontaneous healing, it's the same thing, but then you can get funded. So research is important. We were talking about some other examples this morning like that. That if you say you want to study psychics, you're not going to get funded. But if you say you want to study medical intuitives,
Yeah, that works better.
like the other work I'm doing now is if I say I'm studying auras, no way, but if I say I'm studying biofield, that sounds like, you know,
yeah.
there's something there, so then I can hope to get something.
By the way, do those protect you from smoke and, you know, toxins? What's the you know, biofields and auras? Can they protect people?
When do we get to the pub? You know, about 9:30 tonight. No, we'll talk about it. So the best thing about case reports, case studies, is they're good for generating a hypothesis. Case studies are not testing hypotheses because there's so many variables, there's so many things that can be the reason for the improvement other than your intervention. But it can generate a hypothesis, and the way you test the hypothesis is you do a case series, okay? Because you say, okay, I'm gonna keep an eye out for the next 6 or 10 patients that I treat who have a similar problem, and I'm gonna see if the same treatment helped them, because the chances are the next 10 patients didn't fall in love right before they came to see me. Okay, so we're going to rule that out. So it's a much better way to have a next step from the case study is to do those 6 or 10 patients. Okay. Then we do a small controlled trial, and that trial can either be in this old way of comparing acupuncture to sham acupuncture, or the better way is to compare acupuncture, what you did, to what Western medicine, what biomedicine would have done to treat that same patient. When I say sham acupuncture, do you know what that means? What is sort of being used as sham acupuncture? So there's 2 very different approaches to sham acupuncture. I mean, both of them are based in this faulty logic that says if there are acupuncture points, then there must be places on the skin that are not acupuncture points. So all we have to do is put needles in those non-points, and we've got our control. Okay, well, there's only about 6 things that are wrong with that logic. Most of which, as I said before, you can't design a sham acupuncture treatment if you don't know how real acupuncture works, because you don't know what you're shamming, what you're supposed to sham. If you don't know what the needle is stimulating, then you can't make sure that the sham is not doing the same thing. That is the problem. So much better to do this comparative effectiveness research where you're comparing acupuncture to another active treatment. And then finally you do the big study. So we don't need to go through all of these, but the idea is the case series can begin also to reflect clinical practice. So you could have an individualized treatment protocol. You could say, I don't care how, I just want to treat these patients as seems best for each patient in this series, because they're all going to be different from that first patient I saw. So I'm not going to do a standardized protocol. And what you're doing is really testing the generalizability of the case study. You're seeing, am I going to get the same kind of results that I got with that first patient with all these 10 patients? And then I know I'm onto something. I'm onto some new kind of treatment. I'm testing moxa for cold conditions, and guess what? It's really working for this particular condition. It's different from what the classical texts say. So the real key is, before you get disappointed about a so-called negative trial, acupuncture doesn't work for hiccups. Oh my God, I treated a patient and it does work. Why didn't they get the result? Or you get excited about a new approach to using acupuncture and positive results. In both cases, how do we know that the study was done well enough so we can believe the results? That's what we have. That's the key here. So most of the quality assessment of clinical trials has focused on quality of reporting, because you want to know how confident you are in the results and how easily can you reproduce the results. So you want to make sure they tell you everything they did. You want to make sure they told you the gauge of the needles they used, whether they used unilateral or bilateral needling, what depth of needling did they use. You want to know all of these things, so when you read a study, you need to go over in your head, if I was to try to reproduce this study, is there enough information here? Because if there isn't, I don't really know what they did, and so if I don't know what they did, I can't necessarily believe their conclusions. Okay, so you really need to look at that carefully. So what this has led to several kinds of guidelines for how to report clinical trials. So this started in the biomedical literature. Editors of journals were getting very frustrated that one study would leave out this bit of information and another study would leave out a different bit of information. So they wanted to come up with some standards, a standard set of criteria. So when you write up your article and you submit it to the journal, the editor sends it out for what's called peer review to some of your colleagues who, out of the goodness of their hearts, will take their own time without getting paid for it and review your paper, because you're hoping that someone else, that you want to do as good a job for someone else because you want them to do a good job for you. So that's how the system works. So in the biomedical literature, what they did was they came up with something called CONSORT, which is a little clunky acronym, but it stands for the Consolidated Standards of Reporting Trials. Okay, so they had a whole list of 22 different items, sometimes with sub-items, but it was meant so the editor could send out this checklist along with the article to the reviewer, so the reviewer could look to make sure everything was there in that standardized form. So a group of us got together and said, well, this consort is good, but it won't be good enough to apply as it is to acupuncture research, because the only criterion that we could apply is, was the intervention clearly defined? So that's what consort says. So we took that one item, it was consort item number 4, and we said, that's too general. So we said, what are the kinds of criteria we want so that we can take consort and adapt it for acupuncture research? So I would like to take credit for it, but this other friend of mine, Hugh McPherson, came up with the term STRICTA, which is Standards for Reporting Interventions in Clinical Trials of Acupuncture. So what it did was, as I said, this consort item 4 is give the precise details of the interventions intended for each group and how they were actually administered. Well, what details should be given is what we decided. So we came up with stricta to replace that with what was the rationale for the acupuncture? Why did they choose those particular points? Was it based on classical texts? Was it based on a survey of practitioners? We want to know how they came up with the procedure they did. We want to know, there were 7 items about the needling details, as I said before, the depth of needling, whether you manipulated the needle or not, what the gauge of the needle was, all these kinds of things. 3 items regarding the treatment regimen, simply how often, what was the frequency of treatment, and how often was the frequency, yeah, and the number of treatments. Co-interventions, was there anything else besides the acupuncture? And so how well was the gua sha described? Well enough you could repeat it. What kind of moxa was used? So all of these details are important for whether or not you could repeat the study. Number 5 was practitioner background. Don't we want to know, if a study is negative, who did the acupuncture and what was their training? Was it MDs who took a weekend course or 2? Or was it midwives who were simply trained to deliver a certain series of points? Or was it a comprehensively trained acupuncturist? So we wanted that to be mentioned. And finally, the control, the sham acupuncture, for example, how clearly was that defined? So fortunately now, consort and stricta have been translated into many languages. This was the first translation into Chinese. And what we did when I was at OCOM in the research department, we took these consort and stricta guidelines, which are saying what should be done, what should be done, what should be done, and we turned them into questions so that we could rate the quality of trials. It was just a ridiculous labor of love, because we had 27 questions, each of which had several sub-questions, and then we had to develop a manual which listed the criteria for when we would score a question yes or no, or partial. We could give a partial score under certain circumstances, or was the question not applicable? So we applied that. What we wanted to know at the time was, since that NIH consensus conference on acupuncture, which was in 1997, what was the quality of research for the next 10 years? So we wound up, it was well over 300 clinical trials that we applied this instrument to. And as I said, it was a labor of love, but we did it. So I thought what would be really important is to take this huge document and condense it down for teaching, and to say, what did I think were the minimum number of criteria that could give you some idea of the quality of a research study. So that's how I came up with CLEAR, and it took me a couple of days to come up with the acronym, and it's like when the clouds part, and then suddenly, oh yeah, and then everything became clear. No, I didn't say that. So here we go. 10 criteria. The first one, as I said before, how important I think this is, are the training and the experience of the practitioner stated. Now with all of these criteria, it's not a question of how well they came up with the criteria. I don't want you to judge that. I just want you to judge, are they there or not? It's just reporting. It's not, we don't want to apply judgment here, okay? For instance, in the second criterion, are the inclusion and exclusion criteria presented? So what that means is, you're the researcher, you can decide who the patients are that you want in your study. This is, this is for good and for bad. For example, if you want to study headache, you can say, I want to make sure I don't have any patients in my study whose headache is secondary to a brain tumor. Okay, so that's an exclusion criteria. Okay, you can say that I only want to look at patients who've had migraine at least 6 months and not more than 3 years. You can say, I only want to look at migraines in adolescents. So you decide. So again, your job in applying these criteria is not to look at were these the best criteria they could have used, or would you have used different criteria. You just want to know what they did. Okay, so are the inclusion and exclusion criteria clearly stated? Third, these are supposed to be randomized studies. So is there a clear statement that the patients were assigned to whatever the groups were in a process that was random? Now, how do you do that? Okay, you're not allowed to flip a coin and the patients come in, if it's heads this group, it's tails that group, because most studies are not done with, if you're studying 10,000 patients, then you can flip a coin. The chances are then you're going to wind up with 500 in each group. But if you're studying 20 patients, as so many preliminary pilot studies do, then the chances are good you can get, 13 heads and 7 tails, and that's not going to cut it for research. So the best way to randomly assign patients to groups is, there's tons of sites on the web now that have tables of random numbers, so they'll give you 1s and 2s in what they have worked out as a random sequence. So the first patient is whatever the first number is, the second patient is whatever the second number is, and that's how you do it. What you sometimes find is people will take many more. You write 1 on slips of paper and you write 2s on slips of paper, and you put many more into a bag of these 1s and 2s than you're ever going to have for patients, and you just randomly, well, you stick your hand in, you don't randomly stick your hand in. You stick your hand in and you pick out a number in that, for that patient. You're not allowed, of course, to have a patient walk in and the patient's got, this guy's got long hair and a ponytail, and you say, oh, he's going to be good for the acupuncture group. Okay, so that's what you can't do. So however you randomize, it can't be based on judgment, or it can't be based on anything that would be construed as your bias. Number 4, what does this mean? Demographic and medical history information reported for patients in both groups. So after you've randomized the patients to both groups, you want to present in a table demographics. Say you want to make sure you've got the same number of Anglos and Hispanics in both groups. You want to make sure you've got the same number of men and women in both groups. You want to make sure you've got the same number of people in the 40 and over as you have 40 and under in both groups. So you want to present this, and the same thing with medical history. A really important thing, for example, is how long the patient, the duration of the condition. So you want to have that in both groups, the same. So you're not allowed in a clinical trial to say, whoops, we don't have balance, we got to start randomizing again. I mean, maybe people do it, but legally, morally, it's fattening, it's not good for you. Anyway, you're not allowed to say, whoops, this isn't good, and re-randomize your patients. If you're working with a biostatistician, they'll say you don't do that. So you are allowed to do something called stratify. So if you're doing something where patients can have a duration of treatment, say, a duration of the condition, anywhere from a month to 10 years. So you can stratify. So all the patients who've had the condition for less than 3 years, you can randomize them separately from the patients who've had the condition for from 3 to 10 years. So that way, you'll have a good chance of having the same number of patients with short duration and the same number of patients in long duration in each group. That's called stratifying. You're allowed to do that before the trial starts. Okay. Number 5, are the rationales reported for choice of acupuncture points and treatment protocol? And as you go through the method section of the paper, these things will become clear. So you don't have to remember what I'm saying. You'll see that very often there'll be a subheading, even if you're lucky, they'll say inclusion criteria, another subheading for exclusion criteria, so you could just quickly check it off. They told me. And remember, you're not looking at, are they sufficient? You're just saying, did they present it? Do I know what they did? Okay. So, are the rationales reported for the choice of acupuncture points and treatment protocol? Okay. So yes, they gave me a rationale, and I want to know what that rationale was. I want to know, did they consult 3 different classical and 2 different, did they consult Maciocia to know what acupuncture protocols they should use for endometriosis, for example. So what books did they use, or did they do a survey of practitioners to know what points they should use for low back pain? And we based our protocol on a consensus of 25 practitioners that we sent questionnaires to.
I have a question.
Sure.
What if you do it based on something more subjective, like pulse or palpation, in terms of coming up with a treatment protocol based on palpatory findings, which seems a little subjective, but I know that's typically done in certain styles of
Okay, so let me try to rephrase that in a more general way. What if you want to do a study where you're allowing individualized care, so that you're allowing the practitioner to decide what points based on tongue and pulse, so they can decide what points to use. Okay, so then the problem is research is a kind of compromise, because if you tell the practitioner, do whatever you like, that's fine, but how am I going to repeat that study? How can I be sure? I can also tell the practitioners, do whatever you like, but it may be a whole different range of what they liked to your study. And so I get a different result and I don't know. So it's much better to try, for the sake of research, to do something like that's kind of semi-individualized. So you could say, we're going to come up with 4 different acupuncture point protocols, but each one is geared to a different tongue and pulse and whatever the pattern diagnosis is. So if the pattern diagnosis is this, then they have to use these points. If it's something else, then they can use. So there's kind of room to be semi-individualized in a research study, because that's the balance. I mean, when I start a study, I sit down with the practitioners, and we always start, and I say, push me as much as you can in terms of what you want to do, They say, well, we want to be able to treat differently at each visit. Uh-oh, and I say, how am I going to put that into a protocol? So it's a balance between how does the protocol best reflect clinical practice, and how can I write this up in a way that somebody else can try to repeat it. So that's the balance in a research study. Okay, clinical outcome measures. I want to really be clear on what you did. If you're telling me you did a measure of stress, okay, and I want to know, you can't tell me we used 2 validated, commonly used measures of stress. Well, that's fine. I want to know what they were. And even better, in the appendix, if you put a copy there for me, that's even better of what you did. If you did range of motion, how did you measure the range of motion? So I want to know what you did, so I can initially try to repeat what you did. Was the treatment assessor described as blinded? So that's a really good one. What does that mean? That means, obviously, if you're doing acupuncture, the patient knows whether they're getting, the patient doesn't know whether they're getting the real treatment. The acupuncturist knows whether they're giving the real treatment or the sham treatment, okay? The patient doesn't know, hopefully, going to ask the patients afterwards to guess which treatment they had. Then there's someone else who is, in a real research study, it's much better to have somebody else, not the practitioner, assess the outcome, because you, as a practitioner, knew which you were giving, so you might, and you're also the researcher, so it's never a good idea for the researcher to also be a practitioner, because there's just too much possibility for bias there to influence the results. Okay. So if you're doing, let's say, this new kind of research, comparative outcomes, then the patient knows what they're getting. They know they're getting acupuncture, or they know they're getting a beta blocker, a pill. So that's why it's even more important for the treatment assessor to be blinded, not to know who got which. Sometimes that can be done, I'd even say most of the times it can be done. Sometimes you run into a real problem if the drug that you're comparing the acupuncture to has side effects. Then the treatment assessor gets to recognize the side effects and knows that person's got the drug, and that could influence how the assessment is. So it can be tricky. All these things are really lovely on paper. When you try to do a study, you learn a ton more about research and the problems you encounter than you ever knew when you first tried to design the study. So 9 is where the patient's asked to guess their group assignment. Okay. Now, that's really important, and you don't want to do this at the end of the study. Why wouldn't you want to do this at the end of the study?
Because if they talk to each other and everyone's like, well, I felt exactly the way I did before, then they already know where they are.
Right? That's one really good reason they talk to each other. Even if they don't talk to each other, if somebody improves, they feel they're improving, they're going to think that they got the real treatment. Okay? Not that some people don't improve on the placebo for other reasons, but it's more likely. So you want to ask them, actually, the first time they come in, it's just too much going on. So it's really good to do this the second time. You ask them which group. And the second time, you not only are going to ask them which group they think they're in, but ask them why they thought that, okay? And it's still early enough in the study, you can make a correction if the practitioner is acting in a way to give it away that everybody is guessing. So you can still retrain the practitioner to stop doing that, whatever it is they're doing. And finally, follow-up data, okay? We talked about patients getting better just because they're in the study. It's really important for that reason to do either a month or 3 months or 6 months after you stop treatment to test again to see if you also want to know if any improvement any benefit they got, any improvement after the treatment, was that maintained. Very often placebo improvement happens during the treatment, but it's not maintained, because whatever that desire falls off, that desire to please. So ask the patients. Okay. So how many are we here? We're 2, 4, 8, 24. Okay, that's a pretty good number, or 25 would be a good number. I think groups of 3 is really the ideal. Groups of 4 or 5, some people don't talk, and groups of 1, then you're doing it all your own. Let's try groups of 3. So you guys, your 3 are good to go. One of you turn around and work there. Jim, maybe you can move to. Anyway, find groups of 3, and then. So we've got. Listen up a sec. We've got 2 articles here. So one is the treatment of post-chemo chronic fatigue, okay? And I picked both that are sham controlled trials. So one is the Deng and colleagues study that was done where, I think in New York City, yeah, at Sloan Kettering. And the other one was done in Denmark, and that's acupuncture for relieving menopausal discomfort in breast cancer patients. So both are randomized controlled trials. So let's see. Okay, you guys do criteria 1 to 5 on the back and forth. So there's 2 threesomes that got each of half the criteria for each paper. Okay, so maybe it would be interesting to take the 2 threesomes that did, let's say, the 1 to 5 on the post-chemo paper and see how well they agreed.
Good idea.
Yeah? So, just for fun, for everybody, here's the deal on the post-chemo paper. 101 cancer patients reporting chemo fatigue lasting greater than 2 months, randomized to 6 weeks of once per week true or sham acupuncture. Okay? There was a moderate decrease in fatigue scores between baseline and follow-up in both groups. No statistically significant difference between the groups. So again, the sham worked as well as, it's not that neither worked, it's both of them worked. Okay. Who had 1 to 5? Which of the groups, the 1 to 5 on the, you guys and you guys. Okay, so why don't we just switch it? You tell us 1 and see if you guys agree, then you can do 2 and see if you agree, and let's just do it that way. So 1 is the training and clinical experience.
Yeah,
Yes.
it was on page 1737.
Yep.
Should we read it or just?
Sure.
Oh, okay.
Yeah, good.
So we,
Yeah.
Okay, so all NCKCC acupuncturists are licensed by the New York State Education
Do
Department.
people know where she's reading from? Maybe the page and the
Oh yeah,
paragraph?
it's
or?
on the left side. Before outcome evaluation, the last
Right.
paragraph.
1737. Got it?
So they were trained in human subject research and certified by National Certification Commission for Acupuncture and Oriental Medicine with a minimum of 3 years of practice experience.
That's good. I think we've heard of that National Certification Commission, huh? I think we know what that is. Okay. You guys have anything else on that one, or you got the same
No,
thing?
that was it. I mean,
Good, that was
you
it.
did more details than that.
Yeah.
You know, I mean, that's for 3 years of practice experience. Did they see 2 patients in 3 years? Or? No, you know.
I know, I hear you.
Yeah.
Yeah, no, really, that's what you want. What does that 3 years mean?
That comes
Yeah,
up a lot. I mean, just in terms of,
yeah,
yeah.
yeah. I think it means 3 years in hospital. They're
That
one of the
would be, yeah.
hospitals that take LACs. They're really good about it. So I think it means in hospital. Right. 2. What you guys got on 2?
So what are we doing?
The page right before it, page 1736. Bottom left paragraph. The inclusion criteria were age 18 to 64 years, diagnosed with a malignancy, and having completed a course of chemotherapy at least 60 days prior. Fatigue following, but not before chemo. BFI score 4 or above. Exclusion criteria were hemoglobin less than 3 nanograms. Platelets, so on and so on. And that paragraph has all the exclusion criteria.
BFI, want to remind us what it is?
It's talked about on the first
Yeah.
page, I think.
It's
It's one of
it's
those,
Brief
the brief
fatigue.
fatigue inventory.
Yeah. the brief fatigue. It's the main instrument for
They
measuring
use- they use
fatigue. Yeah.
secondary endpoints as well.
Yep.
Yeah.
Okay, so
Agree, yeah.
good. Number 3?
Okay, the third question was group assignment of patients reported as randomized, is the procedure given? And we found there was actually a subheading under methods entitled appropriately randomization.
Yep.
It says patients were randomly assigned to true or sham acupuncture via fax to a central randomization service. Randomization was implemented using a secure password-protected database, ensuring full allocation concealment. Randomization was in randomly permuted blocks stratified by baseline DFI greater than 6.
Okay, so translation of that means they probably took 4 eligible patients at a time. That means a block, and they assigned 2 to each.
Oh,
You know, and this stratification is what I told you about before. So they decided this. There were BFI is the fatigue index. So they, I guess it's maybe a 1 to 10 scale. So they separately randomized those patients who had less fatigue on a 1 to 5 from those who had 6 to 10, so that they, if you look at their at that table, which we'll look at in a bit, you could see that they had, that was how they equaled both
So
groups.
that was my, I just want to make sure I understand that correctly. They did that so that you didn't have like all the really high scale fatigue. members and
By
the
chance,
low.
that's
Yeah.
right, exactly.
Okay.
Good. So you guys for 4?
Demographic medical history presented.
Yep.
With our table on
Good.
Page 1739, table 2.
Yep.
They could have done more, but they did.
Right. Now, what I don't see here, which they should have told us, is how successful was that stratification of the above 6 and below 6, because I don't see in both groups so it would have been nice to, but anyway,
Yeah.
would be nice to show that.
The score of the stratification.
Yeah.
Yeah. It would be good. It would also be nice to have ethnicities and
Yeah,
economic
definitely.
and stuff like that.
Definitely. Right, especially if you want to repeat that in a place that has a different ethnic ratios than
We
New
have
York.
no idea.
Yeah, New York City is just they only have white guys in New York City. There's very little ethnic diversity in New York City.
We could repeat it in Reading then.
Guys, are okay with that?
Yeah.
Yep. And 5?
And 5, where rationales presented for the choice of acupoints and herbs and treatment parameters, where AOM tags or previous clinical trial cited, where practitioners surveyed. So on the page 1737, we have the table that shows what points, acupuncture points were used. So for the acupuncture group, they would just use the 2 acupuncture points, and for the sham, they would just would be performed the same way as true acupuncture, except for the use of sham acupuncture needles and points that were a few millimeters off the meridians.
Yeah. I think that's a little dicey. I mean, because what does that mean? A few millimeters off the meridian?
Yeah, how
was
they
it
measure it.
consistently done one way or another way? I mean, that would be a little hard to repeat, I think.
Yeah.
Yeah. So I would give them, being generous, I might give them partial. The other thing about that is their rationale, I say, was based on their previous pilot study. So I would have gone and looked up, what that reference was, and then learned how they did. But that's
Right.
good enough.
Yeah.
Yeah.
That's what we.
Yep.
Yeah, you're right, as to how off the points, because it's meaningful to me, did you go off the channel? That's really meaningful in terms of acupuncture.
Off the point in which direction?
Because
Yeah.
I mean, there's a saying, you can miss the point, but don't miss the channel, too.
Yep.
Yeah.
Can I ask a question about, do you think that's too wide of a range of, they talked about the stainless steel needles ranging in size from 1/2 inch to 3 inches long and 32 to 38 gauge, going anywhere from 1/2 inch to 1 inch deep. Is that an acceptable range of?
It's a comfortable range, but the point I'm guessing that the point is The range was not because they used random needles, but because at some points they wanted to go deeper and other points they wanted to go more shallow. And so it would have been good to tell you
Yeah.
which ones were the
Did
deeper.
they consistently go 1 inch deep on
That's
everyone
right.
at the
Well,
same
wouldn't
point?
they-
I
or
would
just-
imagine they were the run points for obesity patients.
But it's an assumption.
That would be my
Yeah.
assumption.
Uh-huh.
They would also have to adjust according to the size of the patient. I mean, you know, if you have this little bitty woman who's all sucked up and she only weighs 98 pounds, you might be only able to go in very shallow, but some
Right,
fat guy, you know,
right. So that
maybe more.
would
Yeah,
be
but it
more
would be
for,
good to know with that.
Right, it would be good
Yeah.
to know,
Yeah,
but there does have to be a range.
totally.
I mean, that's more with you guys' experience to know what more you would like to know to be able to repeat it. And that's really
Yeah.
the key here.
That we'd
And
like to know.
Patients.
Yeah, so being generous, you could give that a partial
Yeah.
Yeah.
score,
Yeah.
being generous. Okay, which guys had you had 6 to 10 on that study? And you guys, okay, good. So let's go for 6.
Well, 6 is in that same paragraph they were just discussing. Where they actually, because it's where the acupuncture control comparison treatments described in sufficient detail, and they talked about, you know, the attempts to get the dachi, and then what they did with the sham acupuncture, and how they moved it a few millimeters, which I still question, because we don't know exactly how wide a meridian even is, so, I mean, a few millimeters off a meridian might be off the meridian, and it might not be off the meridian, so I don't know how they didn't describe how they decided how wide each
Right.
of these meridians
Is it
were.
a 2-lane highway or a 4-lane
Or
highway?
is it
Right,
some
that's
back,
right.
you
A
know,
back road?
trail
right.
of the deer or something, you know? I mean, it was really, that part
Yeah.
really didn't seem like you could
Yeah.
reproduce it. But they did make a lot of description, let's put it that way. It's just not probably significant. Especially when you consider one point is stomach 36, that could be as big as a quarter.
Yeah, agreed. Not really good enough. Not really good enough. 7?
Okay, where the clinical endpoints or outcomes described in sufficient detail, you could use them to repeat the study. I mean, we have this table 4 with all of these criteria and the results from the regular acupuncture and the placebo acupuncture. So I suppose if, you know, we had the information in number 6, so like the BFI, the HADS, depression score, anxiety score, overall emotional, functional. So if we had the ability to reproduce the study, then theoretically the results should be similar and we could reproduce them, but that's hypothetical.
Okay, so I think there's a mix-up here about what the term outcomes mean.
Yeah.
Outcomes don't mean results.
Yeah.
Outcomes mean the measures you used.
Indeed.
A clinical outcome measure, yeah. So,
Yeah, the outcome measures were the BFI,
Yeah.
HADS, the FACT.
Yeah, I just listed those, the functional
There was
ability.
Right.
table for it, yeah.
right, so you would have to go and look up the references they gave and decide really were those references good enough, and the chances
They're all
are they are.
validated
Yeah.
tools for outcomes.
Right.
Don't they usually state in there with the validation of the, I mean, shouldn't
They
they state
should.
in there?
They should,
That it- how they-
and hopefully, in that if you look at the reference, then you'll
Right.
see.
But it would be nice to know that, you know, it had been validated by
Right.
5 previous studies.
I mean, that's an important thing in research, is not to simply make up your own set of questions,
Right,
because you have to go through a really accepted procedure, which you nail this, you have to validate your form. And then, of course, as we were talking about before, there's a kind of 3 or 4 different kinds of validation, you know, so my favorite is simply called street validation, which is, you know, is that do people really understand, you know, do commonly understand what the questions mean? You have to take a target patient population and see if they really understand what they mean before you can use them.
right.
Yeah.
But in most research I've read, they usually at least have some of that written in here. We validated it twice before we decided to use it or whatever. And I don't see that in this study at all, or in this write-up. I mean,
Yep.
not,
Yep.
I don't know how they validated it.
Well, you don't have to validate it if somebody else has validated it.
Right, but they didn't
Yeah.
state
Right.
that this had been previously validated, therefore we don't have to
That's
validate
right.
it.
That's
So
right.
I have to look it up now, which is cumbersome and not what I should have to do.
Got it. Got it. Okay. So that was 7, so we're back to 8.
Page 1736, about midway on the second column. Blinding, patients and evaluators, but not study acupuncturists, were blinded to the group
Great.
assignment.
Good. And 9?
We did not find that they were asked what they thought about being in which group during the study. They were told afterwards and given the option to have real acupuncture if they wanted, but not during the study. We couldn't find anything that said they were even asked if they thought they were in a...
Well, they snuck it in here.
Yeah, the sentence after the one she just
Right,
read
that's
says
right.
it.
If you look under the blinding that they just did on 1736, the second sentence there.
Okay. It doesn't say when, but yes.
Yeah, and it doesn't say when they, right. That's right. So that would be again, a generous partial. But where, if they were asked, where do they give the results of
Of what the outcome.
what they found?
Oh, yeah.
Oh, yeah. Halfway down table 3.
Allocation of belief.
Oh. Table 3. Yes, table 3. Good. Table 3, patient allocation belief. Good. So, more patients. Patients who guessed sham were more likely to be in the sham group. Patients who guessed acupuncture were more likely to be in the acupuncture group. Patients who were unsure were equally divided. Not their allegiances. Okay, so 9, right?
That was 9.
That was 9, sorry.
Does that
10.
mean They had truly had a sense of what they were experiencing? It was accurate?
Well, it wasn't as, you'd more guessed the right, and the question is, if all of them in the acupuncture group guessed acupuncture and all in the other guessed, then you would say that something was wrong. That it was not a good study.
But it's not statistically.
But there's no criteria for how many, should be able to guess whether the study is valid. 10? Scott, the last one. Follow up?
6 months.
Yeah.
There's a 6 month.
Right, there was follow-up. Okay. So let's finish up then with who had 1 to 5 on menopausal discomfort.
I had something to point out in this article, just a small sort of tell of something. In their discussion, when they generously say a possibility is that sham acupuncture is not entirely inert. Okay, that's nice. That's better than before.
Yep.
But later on they say skin penetration and dachi sensation are not essential as effective acupuncture. Skin stimulation per se may also have a small therapeutic effect. That's an assumption on their part. That word small, that's based on maybe their understanding of dachi, but not their understanding of some other forms of acupuncture where we actually feel it might have a very big effect.
Yes.
Their inclusion of the word small there
Yes.
shows a misunderstanding and perhaps a prejudice on their part.
I agree. Good. Okay, kick off with 1. So we're on the second study now.
Number one, it asked were the training and clinical experience of the acupuncturist stated. I would say no, not really. It just said 2 experienced acupuncturists.
See, all they say here is 2 experienced
Right.
acupuncturists. We have no idea.
No education, no years
No
of
idea.
experience.
Number 2? Oh, you guys have 2.
Where inclusion and exclusion criteria patient selection presented.
Yeah.
Yes, but, well, it actually was a lot better than the other questions. There was more information. Excluded were post-operative breast cancer patients who
Yep.
were on HRT or who had diagnosed metastatic breast cancer. Included was not specific enough. It gave an age range, 61 years was the median, 45 to 76 was the age range. And they just said it was, these were, the people that were chosen for the studies were those with self-reported problems with sleeping and hot flashes, right? So the exclusion was somewhat clear, but the inclusion could have been a lot better.
Got it?
Number 3.
3?
Were patients assigned to the treatment group and the control or comparison group by a process described as randomized? It's on page 321, under the first paragraph, where they talk about randomization was done by the acupuncturist. The participant personally withdrew a sealed envelope from a plastic bag and was randomly allocated to either of the 3 groups, and then they described the groups. And so they talk a little bit about how they randomly assigned them. Yeah.
But not how. Well,
Yeah,
yeah, from
they
the
do, 'cause
sealed
the
envelope.
participant,
Yeah, from the sealed
took
envelope,
the
yeah.
envelope out of the
Good.
bag, yeah.
Yeah, that's good enough.
Yeah.
And 3?
Well, we agree with them that they, gave some information that it was random because it was a sealed envelope.
Yep.
But it doesn't follow through with anything else, like what they knew or suspected, or, they did say something about, I don't remember where it is, something about the acupuncturist. They said group 1 and 2 were both patient and investigator blinded. Because they had
But
3
that's-
treatment groups, which is, they say, at that time, I guess, was unusual.
Right, but
Could
that's a
they-
different criterion.
That's a different criteria, okay. Do you want me to do 4?
Yes.
Yeah, where demographic and
Yes.
medical history information presented for the patients assigned to the treatment and control or comparison groups. That was also, number 4, that was inadequate also. All patients were in the post-operative period from 6 months to 5 years. They didn't state anything about any particular ethnic group, socioeconomic status, comorbidities, what kind of breast cancer they had. They just said that they were post-operative, and that they were in the post-operative period from 6 months to 5 years. And because of the age range and that range and the different types of breast cancer, it is kind of, they could have given us a lot more information.
Yeah, so there was information in table 1, which is at the bottom.
Table 1, yeah, we just, we thought that was information on where they were at, like in regards to their treatment, but not in regards to, yeah, you're right, when they presented. I was thinking of other problems that they might have had.
Right, comorbidities would have been good
Yeah.
to know, yeah. Unless they were excluded, unless any other comorbidities, so that's
Well,
not
all they
clear.
mentioned was the HRT groups
Right.
and the diagnosed
Right.
metastatic cancer, yeah.
Got it.
So that was actually better, that was more extensively done than the other questions, I think.
Good. So 5?
Number 5, asked if, what the rationales were presented the choice of acupoints and or herbs for the treatment. And we found, it was a little vague, it just said selected from the textbook Practice of Acupuncture. But didn't really say why they selected those specifically.
So that's page,
They did
Oh,
say,
321, a little more than halfway down.
yeah, second, end of second paragraph.
Yes.
Yeah.
And previous clinical trials, on the first page, they talked about a couple of reviews, but that was about it.
Yeah, so not very good
Yeah.
to base it on one textbook.
And we did not see where they stated that practitioners were surveyed.
Right.
Okay, so who did 6 to 10? This and the other 6 to 10 group. Good. So I can start with 6.
Were the acupuncture and control comparison treatments described in sufficient detail that you could repeat them? We felt that they were pretty well described.
Can everybody hear?
We felt that they were pretty well described on page 321, group 1 included 31 patients who had acupuncture, group 2 included 29 patients who had sham, and group 3 included 34 with no treatment. Group 1 and 2 were both patient and investigator one, which also kind of answers 8.
But that describes the groups, but what about the actual acupuncture and control? That's what the question is asking more.
If you go to the next paragraph,
Good.
group 1 had manual acupuncture and predetermined bilateral points for 15 to 20 minutes once a week for 5 consecutive weeks. They used true points along the meridians for acupuncture. The points were heart 6, kidney 3, spleen 6, liver 3. These points were located on the wrist, ankle,
I
and
have to
foot.
think that's really helpful.
Okay.
The points
Yeah.
were located on the wrist, ankle, and foot.
Yeah.
That's great. Who are they talking to when they say that?
And so they just go on
Yeah.
to describe all of the sham and control groups.
The sham part, it's like the same as the group, not the group, the study that not on the meridian, and then didn't explain how far from the actual meridian, which might be outside the meridian, that's what it's saying, and then same region. So not really specifically, that part is not more,
Yeah, not
really
yeah.
specific.
Not clear again about the sham.
Right.
So 7. You guys?
Oh, for
7.
us?
Yeah.
Oh, this is interesting. Where the clinical endpoints or outcome measures described in sufficient detail that you could use them to repeat the study. I don't think, we say no, he says yes. We don't think we can repeat the study, and the reason is, first and foremost, they're not even giving us the duration or the dosage of the hormones that they're taking in conjunction to the acupuncture.
Yes.
And then the most important thing we found here, it says that hormone treatments has been only effective therapy, but the habit study showed an increased number of relapse among breast cancer patients receiving hormone replacement therapy. Consequently, treatment is no longer advisable. So you
Well,
can't even repeat this.
Sure, but is that criterion 7?
For the clinical endpoints or the, well, we're not understanding this question maybe.
Yeah, that's why I put in the parenthesis, because it means not what the results were, but what did they use to get the results. The means used to assess the effectiveness.
So when you look at it that way, if they're like, they wrote a log about their symptoms.
Yes.
Okay?
Mhm.
And then they turned around, they took that data and they made some pretty nifty little charts that showed this is where we started, and then day 2 and day 3, and this is the change, and because of that, I said yes. So that
You
was
can
my-
sort of infer the methodology from the charts, but they didn't
But,
write specifically.
yeah, but then you're asking, can you
Well,
repeat the
there was a
study?
log here.
But there's not enough detailed information to be able to repeat this.
The log book was filled in
They're down.
3 days. After each treatment, 6 weeks, 12 weeks,
It was filled in by the patient?
Yes.
Yes.
Yeah.
their
so
sleep disturbances
there's
were
more-
rated as yes and
it's more
no, you know,
subjective.
but it is, it's something.
Well, it's gotta be, I mean, how could it not be subjective?
You know,
Right.
That's all
it's, even if we talk about sleep, you know, if their sleep was really bad, they're not gonna say, yes, it was good.
Well,
but this
maybe not
question is asking
subjective,
about the
but
method
not
stuff.
uniform. Because it's a log, I mean, it
But
was a
aren't
log.
you asking
Well-
about the method of this?
I'm asking, how did they collect the data?
And can you do it?
Okay,
So-
so could you do it, if you were repeating the study, could you get the same data collected, not, not,
accurate.
Well, it's not the question. The question as I'm hearing it is like, okay, at these intervals, we're gonna have these people
Yeah.
log, okay? That's just a fact of it.
Mm-hmm.
Your hot flashes are a real nuisance, or they're not, you slept well or you didn't, and that's what we're doing. We're collecting that data and
collecting
turning
that
those into,
subject, that's
into tables.
tables?
And it's just that, it's not
Yeah.
how good were the questions and,
See, I mean, but that's always the problem with collecting subjective data, you know, and that's why it'd be good to also have that, as they did, they also have the estradiol level as a kind of objective outcome. So they did both. So I would say that that's okay, yeah. 8. What show are we doing?
8.
Watch.
Were the patient asked to validate placebo sham control treatment?
That's 9.
No, 8.
No.
Well, you already gave the answer.
I'm sorry.
Last time.
Was assessor treatment effectiveness described as a
Yeah.
blinded? We still thought this assessor is same as investigator. So we saw the page.
They were
Yeah.
Yeah.
321, first paragraph of variant.
Okay. 9, did you find?
We didn't find 9, were
I know.
patients asked to validate the.
I know, sometimes it's harder to,
well.
because you keep looking, you think you missed it, but
Yeah,
no,
well,
I don't, they
By
didn't.
virtue of not finding it anywhere on here,
No,
I
they,
said
no,
no.
That's right.
we went down to 9 and they didn't have
They
it.
did
Call me
not
logical.
ask. Okay. And did they do any follow-up?
No.
No. So,
They
no
did
and
all
no.
from that.
They didn't do follow-up?
Not in this one. Oh, wait, the
Yeah,
effect
they
came
did.
after the
They
second?
saw the effect was
Yeah, yeah, yeah.
They-
12 weeks after.
Yeah, 12
They
weeks
followed
is-
up and they saw that the sham acupuncture was not effective, but
At
the
all.
actual, yes.
Acupuncture was,
Right.
yeah. Did that.
Yeah, that's on the back page, on 323.
It's all over.
That first paragraph is continued, the effect we're seeing in the therapy period in at least 12 weeks after acupuncture seen.
Okay, so this exercise took a little longer than I thought, so I just want to leave you with a couple of ideas on getting involved in research, but I'll just flip through these slides. For those of you who talk to me and say, you know, what kind of research can we do here? How can I personally get in research? You're not going to have to set up a study from the start. You're going to hopefully work with researchers who know how to do it, but I want acupuncturists to be able to sit at the table when the study is designed so that the researchers know what you guys do in the real world. That's really important. So it's a matter of learning enough jargon, because there's a lot of research language so that you know when issues come up what they're talking about. So that's what I would hope you guys could, those who are interested in research, that's your role, is not to design the study, but to be there when it is designed, so they're not simply handing you something that has a lot of glaring problems to it from your perspective. We talked a little bit about the importance of publishing case reports. I really think learning how to write a case report should be part of the DOM training. Okay. So I don't know if it is with you guys or not.
It is.
But good, it is good. Okay. PBRN is a practitioner-based research network. We talked a little about that. The value of that is especially when, I mean, there are very few acupuncture colleges now who have electronic medical records. It's really expensive. It's a whole big deal to switch over from the manual and the physical storage.
They're not
of the
easy to
records.
use.
The what?
They're not easy to use. It's all
really?
a hoax.
Well,
Terrible.
it's not a
Trust
hoax,
me.
it's also what kind of data is collected and how to get it. The whole point is you want to have not just clinicians setting it up, but you want to have researchers help to set it up so that it becomes a research-friendly way of doing it at the same time as you're collecting data. And I'm talking really about what kind of research can come out of the patient flow in the clinic. What can be learned there? And a PBRN, a practitioner-based research network, is you set up a standardized form so that it becomes easy for you to fill it out, and then it gets sorted and stored computer-based. You learn how to do it here. When you go out into your practice, then you can keep funneling in and keep sending in case reports, so it builds up so that someday someone is going to be out there and they've got a patient, they can tap into this database and they can see how 3 others of you treated that similar kinds of patients, and you can learn from each other. That's the real value of that. In terms of becoming familiar with clinical trials, I know the DOM program is always packed. It would be just great if there could be a small group of you, if not all of you, to sort of bring in a research study and just talk about it each time and rotate who does it, just an idea. If you are serious at all about learning about research, come to the next Society of Acupuncture Research Conference is this November in Boston. It's going to be a real interesting experiment because there are 2 other societies that are meeting at the same time. One is called the Society for Integrative Oncology, and the other is the Fascia. And they're meeting at the same time, and we're going to have one day where all 3 overlap. Not overlap, but physically are present in the same. And we're going to have a program on that day of talks that are appealing to the overlap between all 3. So we're going to try it out. It's an experiment because there are just a proliferation of these scientific meetings. So we're looking to have 3 meetings that have some overlap and see if we can make that happen. This is a great website for case reports. I hope whoever's talking about case reports here at Yosan knows about it and can tell you. They have terrific guidelines and checklists for how to publish case reports, and they're very CAM-friendly and these kinds of things. So, for instance, they're going to ask you, what's unique about the case. They're going to ask you to write patient information, the whole family, including their diet, lifestyle, and genetic information in the case. To talk about milestones of your diagnosis and the intervention. And finally, what's really interesting about to put into your case study aspects of what the patient shared about his or her perspective of experience in terms of the treatment. So it's a very helpful outline and guideline for what should be in a case study. This was a research network that was begun at OCOM, which is sputtering along a bit. As always, there's a problem of one person to really head it up and keep going, but I liked it because it's just this wonderful acronym again. They called it CHI Partner, and it stands for Quality and Improvement, Practitioners and Researchers Together, Networking, Educating, and Researching. So somebody took a long time to come up with that acronym. But anyway, it's a way of, with a standardized form of funneling in experience from your own patients. It's free. You can go online and just sign up, and you can, I think the only requirement if you want to join is to make a commitment to send in at least 2 case studies a year so they can start really building it up. And the idea then the whole database will be searchable by the chief complaint, by the acupuncture point selection, by the herbal formula, or by symptoms. AccuTrials is a database that I helped to set up at OCOM. It's an ongoing database of every clinical trial in English language in any country that's been done and published. And the point of it is, it's searchable, unlike Medline, it's searchable by keywords that are relevant to acupuncture. So you can find out which studies used what kind of needling. You can search it in really important ways that are relevant to acupuncture interventions, ways that I said we can't find on Medline. It's updated monthly, mainly from PubMed, but we also have 16 AOM journals at OCOM that are not indexed in Medline that also get searched. So it currently, this was 900 2 years ago, so it now has about 1,200 is what I heard indexed citations, continuously updated. How to become familiar with results of clinical trials. If you become a student member of the Society for Acupuncture Research, you get monthly updates of acupuncture research that are annotated. That's free. They also have a free library that's supported by a kind of network system of acupuncturists, chiropractors, and naturopaths in Oregon, but they support the work of SAR, so there are a whole series of evidence-based assessments of acupuncture for every condition. So you can find an assessment of the acupuncture research for migraine, or for osteoarthritis, or for menopausal symptoms. So they now have, I would guess, about 15 different evidence-based assessments for different conditions. This is a free library for all members of SAR. The student registration rates for the SAR conference.
Does the SAR include any research for herbal remedies?
Not yet. That's what we're hoping to do. Yeah, I know. The herbal research is a whole nother problem because some of it is single herbs, some of it is animals, some of it, it's not all clinical research, it's a whole area, so it's really there. They're hoping first, before they get to that, to include case reports and case studies.
Sure.
Yeah.
Thank you.
So right now it includes clinical trials and systematic reviews, both. Okay. Hopefully participate in the design of clinical research, get to the fact that where you can write up a publishable case report, hopefully create and contribute to a PBRN, this practitioner-based research network, become familiar with clinical trial results, join SAR, and finally, self-explanatory.
Thank you.